Didn't used to do that. Never brought my glass for my talks. But again, it's better than the alternative of not getting old. All right. So the title of the management of non-small cell lung cancer, I was telling the fellows yesterday that the lecture that I received as a fellow have absolutely nothing that it would be relevant today. And it would be absolutely impossible to cover the management of non-small cell lung cancer in 45 minutes. In fact, perhaps even the management of patients with an EGFR mutation would take 45 minutes. So I thought that I should give you an update of this year's ASCO because it was probably the most impactful in terms of consequent to the daily practice in a long time. These are my conflict of interest, which are none. And first, I'm going to talk a little bit about small cell, but there was something that was, I think, very impactful. And when we talk about conflict of interest, sometimes it's good to tell you what the conflict of interest is from the point of view of bias. This is what I always thought, and here you have it. Prove that I was right all along. So I'm going to give you one of those. Then I'm going to talk a little bit about EGFR targeting in the adjuvant setting. And then what to do when erlotinib doesn't work anymore, or afatinib for that matter. Briefly on second line for patients with an ALK translocation. And yes, perhaps you don't have many patients in your practice with an ALK translocation, but we certainly do. And I think there is a clear explanation for that. I'll come back to that in a minute. Talk briefly about ramucirumab, which I suspect you know more than I do, because this drug was initially approved for an indication that I do not treat. And then talk a little bit about expanding molecular targets. And you may have seen that the NCCN guidelines now have a much stronger statement regarding molecular profiling in non-small cell lung cancer. And then immunotherapy, which really has revolutionized our research in this area. All right. So this was a study presented at ASCO this year from Japan, looking at the role of prophylactic cranial radiation in patients with extensive stage small cell that had responded to chemotherapy. And that is basically mimicking a trial from Europe. And that actually made into the NCCN guidelines as a recommendation. So patients that had been treated for extensive stage small cell with a palliative intent, the recommendation was to give them prophylactic cranial radiation. And that's based on the fact that in this European study, patients had a better survival. But the trial had a few problems. If you look at the survival in the trial, both arms actually seem to have done pretty poorly, although there was a survival advantage in having PCI. But perhaps more important, there was lack of imaging to confirm that the patients were actually being treated prophylactically versus, in fact, they had disease and they were being treated for the presence of metastatic disease. So Japanese did it differently. If patients had a response, they had to have an MRI to show that they didn't have it, and in fact, it was being given in a prophylactic setting. I have lots of slides to cover, so I will be quick on this. 25 gray and 10 fractions. The European study also allowed for different total doses and different fractionation as well, which is another potential criticism. They perform an interim analysis, and the trial was stopped because of futility. There was zero chance that prophylactic cranial radiation would lead to a survival improvement. And this is the study flow. As it turns out, patients that had received prophylactic cranial radiation had less detectable metastatic disease to the brain. I guess that's expected. But you can start to see the problem here. The overall progression-free survival, there was no difference whatsoever. And perhaps a little distressing, the survival signal seemed to be worse if you had developed prophylactic cranial radiation, if you had received prophylactic cranial radiation. And it was a futility analysis because the chance that the curves would cross again and then it would be in favor of the prophylactic cranial radiation was considered to be zero. So this was an absolutely spectacularly negative trial for the role of prophylactic coronary radiation in patients with extensive stage small cell. I will say that at the University of Washington, we never incorporated prophylactic coronary radiation for patients with extensive stage. I think that this would be a very high bar to cross, in my opinion. Remember, these patients are not going to be treated with a curative intent, so very different from the limited stage small cell, where we can perhaps cure 1 in 5 patients that we treat. Here, the chance of cure is 0. And because the chance of cure is 0, they just finished 4 cycles of chemotherapy. Most of them responded well. That's a criteria to receive prophylactic coronary radiation. And they now can enjoy a few months until their disease becomes active again. And once it becomes active again, their time off treatment will be extremely short for the rest of their life until they die of the disease. So now that they're feeling well and they can enjoy a few months of feeling well, let's give them prophylactic coronary radiation. So they can be committed to that and also have recovery from the toxicities of it. That always seemed to me like a terrible idea. And now I have data to support that. So I don't care about the European data. I'm going to stay with this one. All right, so I'm going to move right along to the role of EGFR targeting in the adjuvant setting. This is a trial that we conducted at the University of Washington. Patients with stage 1B to 3A non-small cell lung cancer were treated or not per investigator with adjuvant chemotherapy, and then they were randomized based in stratification factors, which obviously included the decision to give or not to give adjuvant therapy, to be treated with erlotinib or placebo in a 2-to-1 randomization. This trial did not select for patients with an EGFR mutation. Every patient was a candidate for it. And in fact, EGFR was tested by FISH only in the stratification. So there is potentially an imbalance between arms of patients treated with patients with an EGFR mutation. So let me just move to the patient characteristics. As it turns out, it were fairly well balanced, although people in the placebo seem to receive numerically little higher rates of chemotherapy. And this is the overall disease-free survival plot for the entire study, which was absolutely negative. So this is a negative trial. It did not change the progression-free survival to give erlotinib after surgery and or chemotherapy. However, I think that most people that do lung cancer didn't really care about the overall results of the trial. We were much more interested in the subgroup analysis of patients that had an EGFR mutation. Treatment was fairly well tolerated. The discontinuation rate here was higher than you would observe in the metastatic setting because the degree of incentive to continue on the drug is very different in the adjuvant setting. Okay, so about 161 patients in this trial had an EGFR mutation, and 102 were randomized to erlotinib, and 59 were randomized to placebo. The vast majority were females, and about 50% of the patients treated with erlotinib were actually of Asian descent. And as one would expect, the vast majority were never smokers. Remember, stratification did not include EGFR mutation analysis, and there is an imbalance of staging between the two arms. Patients randomized to the placebo seem to have higher clinical staging. So you need to keep that in mind once you look at the overall results of the trial. On the other hand, and as a consequence of that, patients that were in the placebo had higher rates of chemotherapy because they have higher clinical stages. All right, so the treatment for patients with an EGFR mutation was actually delivered. That's important to know. And here is the disease-free survival, which is much better in patients treated with erlotinib. In fact, the hazard ratio here is 0.6, so it's a 40% improvement in disease-free survival. You know, obviously the data for overall survival is incredibly mature at this point, but there is a 40% decrease in the risk of recurrence if you've been randomized to receive erlotinib. Well, I showed you that there was an imbalance in the staging, so that would play a major role in the risk of recurrence, right? Well, that's the adjusted data. So the adjusted Cox analysis, which now incorporates staging into the model, the hazard ratio was about the same, actually. So a 40% decrease in the chance of recurrence. We had our meeting of the NCCN panel in the beginning of July, so about 2 or 3 weeks after this data came out, and it did not make into the guidelines. I can tell you later if you want to know what my take on it is, but we'll leave that for later. So EGFR targeting, this is an area that things are changing tremendously. So about 50% of patients that have evidence of progression on erlotinib will have a T790M mutation. You know, we were trying to get out of this terminology of a new acquired mutation because we don't really know for sure if it's acquired or not. But the T790M is like this. You have the groove where the drug gets in. T790M makes the groove like this, so the drug doesn't get in anymore. And there have been multiple attempts to try to overcome erlotinib resistance. Perhaps the most effective one has been the combination of afatinib and cetuximab, two drugs that are available, with a response rate of about 40%. That treatment is incredibly toxic from a rash standpoint. So it's really hard to tolerate, and it's obviously very expensive as well. There is really no role to use afatinib as a second-line therapy for patients with evidence of disease progression or erlotinib. So this is the data from afatinib and cetuximab. As you can see here, it's a pretty impressive waterfall plot. Most patients seem to have disease control and some tumor shrinkage as well. And as I said, there is really no role for afatinib. The response rate is extremely low. All right. So there are two drugs that are both in clinical development. I think both of them have actually been granted a priority status by the FDA. So AZD9291 is an irreversible EGFR inhibitor, and both drugs have the other drug that I'm going to talk about has the same characteristic as well. They have limited activity against EGFR wild type. So as you see, they cause very little rash or diarrhea. So that's a major difference in comparison with erlotinib. The development of the two drugs have been different. AZD9291 has allowed patients with tumor progression that do not have a T790M. The other drug, CO1686, has not allowed in their trials patients without tumors without the T790M. So the data on 9291, those are both very large phase 1-2 trials. 100% of patients had received a prior oral TKI, and the median number of previous treatments were 3. The treatment was well tolerated, so any grade 3 toxicity was seen in only 24% of patients, and serious adverse events were seen in 19%. But as you can see here, grade 3 rash, very different from erlotinib, was only seen in 3% of patients. Erlotinib would be about 3 times higher, the rates. And hyperglycemia was seen in only 3 cases, and none of them were grade 3. If you don't know the data on CO1686, you may be sitting there thinking, why is he showing a negative data on hyperglycemia? So hold that thought. So this is the response rate in patients that have a T790M and those that do not. So as you can see, the response rates in tumors that have a T790M is very impressive. in this second-line setting. But you also see responses in patients in tumors that do not have a T790M mutation. So much less impressive, but certainly with activity. Waterfall plot, as you can see, the vast majority of patients have response to the drug. And if you look at the response in patients that have a T790M, then the waterfall plot is even more impressive. Progression-free survival for patients that have a T790M, the median progression-free survival seems to be above 36 weeks. So that's very impressive data. Okay, so CO1686.
Why does that mutation result in better effectiveness for this drug?
Well, both drugs were designed to overcome T790M. I think that if we don't know exactly what the mechanism of resistance, it may be a parallel pathway, and then continue to inhibit the EGFR may not make a difference. And as you know, one of the known mechanisms of resistance is MET amplification, and that the EGFR shouldn't make that much difference because it's a bypass pathway. All right, so this drug was also designed to spare EGFR wild type. Again, a fairly large phase 1/2 trial. Here, everybody had to have a tumor with a T790M, and 10% of patients had a history of diabetes. You see, you keep talking about glucose. What's up with that? Rash was seen in only 4% of patients, and all of them were grade 1. So that this drug has even less rash than the AZD9291. No cases of grade 3 diarrhea, but hyperglycemia, so grade 1, that's upper limit and less than 160, was seen in 19% of cases. Grade 2, 160 to 250 in 11%, and grade 3, 250 to less than 500 in 22% of cases, which means that a very significant proportion of patients have to go in metformin. In fact, I hear to the grapevine, we just opened a trial at the University of Washington for patients with a T790M with CO1686. I heard to the grapevine that they believe that metformin also improves other side effects of the drug that have nothing to do with hyperglycemia, namely the fatigue. So this is a waterfall plot, different doses because this was a phase 1/2 trial. But as you can see, the response is very impressive to CO1686 as well. And a very impressive progression-free survival curve as well. So remember when we were super excited that we found out that patients with an EGFR mutation could survive 2.5 to 3 years with non-small cell lung cancer? I think that we are on the cusp of telling them that they can be 2 or 3 years taking a pill without ever seeing chemotherapy. I think that is certainly possible. So this is incredibly exciting. All right, so there was some interesting data regarding the use of bevacizumab in patients with an EGFR mutation. This is the baseline that we're going to be working with. This table here shows the progression-free survival with erlotinib, gefitinib, and afatinib in patients with an EGFR mutation when treated in first line. So as you can see, it's as low, this is all in the randomized trials, it's as low as 9.2 and perhaps as high as 13.7. That's the progression-free survival that you see in these cases. There are a lot of basic rationale why bevacizumab would be synergistic with EGFR inhibition. I like to joke with the fellows that we can find a biological reason for pretty much anything, whether it's correct or not, it's a different story. But this is a trial called Beta Lung. This was a random, capitalizing in that potential synergism from a biological standpoint. This was a second-line trial where everybody got treated with erlotinib, and then they were randomized to receive bevacizumab or not in second line. And as you can see, this trial was spectacularly negative as well. There was absolutely no evidence that bevacizumab made a difference in this setting. But if you look at the subgroup analysis, which obviously one should only do in an exploratory fashion, if you look at the ones that have mutation of EGFR, they seem to benefit quite a bit from the combination. I mean, it doesn't reach statistically significant, it's still crossing 1.0, but the hazard ratio there is less than 0.5. So whatever it's worth, very small groups, obviously only hypothesis generating, and here's the hypothesis. So this trial, also from Asia, treated patients with EGFR mutation in first line to receive erlotinib by itself or erlotinib in combination with bevacizumab. This is a very impressive piece of data. Look at the rates of current smokers. Remember, this is all people with an EGFR mutation. So, you look at these percentages and it gives you a reason to pause. I've never seen this high rates of current smokers in any mutation trial that I'm aware of. Well, as it turns out, the addition of bevacizumab led to a very significant improvement in progression-free survival when added to erlotinib, with a median progression-free survival that had not been seen to this degree ever of 16 months. So is that the standard of care? I can tell you that also did not make into the NCCN guidelines as a standard of care. There is a confirmative trial that was really not going anywhere, and I suspect that will pick up some steam now based on this data. As it turns out, there may be a difference from different mutations. We always knew that the tumors with an exon 19 deletion did a little bit better than those that have an L858R on exon 21. And the response rates were very high either way. And the treatment was pretty well tolerated, so the downside of incorporating the bevacizumab is relatively small. No, so if you look here, the things that were highlighted as showing higher rates of difference were hypertension and proteinuria. Our group at University of Washington actually showed that the proteinuria is clinically irrelevant in more than 250 patients that we looked at. We never made a medical decision based on how high their protein was in the urine. Yes, we did. This is, again, going back to the data from this study of 16 months of disease of progression-free survival versus multiple other data. So this seems to stand out. Does it need to be confirmed? Of course, that would be desirable. But it's a positive trial, no question about it. All right, so for those that are skeptical that they will ever see someone with an ALK translocation, I apologize. This is second-line therapy for patients with an ALK translocation. So this is obviously had been published at the New England Journal of Medicine, is more one of these cases where a drug gets approved by the FDA based on phase 1 data, and I think that that's great. The reason that we had to do very large randomized phase 3 trials is because we understood nothing about the biology, and our benefits were very marginal. Now, if we have drugs that make a huge difference, drugs can be approved based on phase 1 data. So ceritinib, phase 1/2 trial, 130 patients. One of the doctors in our group is one of the authors of this paper. Phase 1, so between 50 and 750 milligrams, which is actually the approved dose. A 58% response rate, and if patients had been treated previously with crizotinib, the response rate seems to be about the same, interesting enough, and a progression-free survival of 7 months. At ASCO, they presented the expansion data from the same trial, now 246 patients. Grade 3 and 4 toxicities, diarrhea 6, nausea 4, ALT increase 27. I would say that I find these numbers surprisingly low. So here's my caveat. I think that this dose is too high. This is basically the same data showing a response rate that it's fairly high. This is obviously a pretty impressive waterfall plot. And the ones in yellow are those that had received crizotinib, and those in blue are those that had not received crizotinib before. And here you have 3 Kaplan-Meier curves. You have everybody on the study, which is obviously the middle curve. Then you have those that had seen crizotinib before and those that had never seen crizotinib. Here, the median for those that had seen crizotinib is 6.9 months. So very close to the data published at New England Journal of Medicine, which I think was 7. Well, let's talk a little bit about the importance of molecular profiling in a more broad way. So as you may know, crizotinib was actually not developed as an ALK inhibitor, but rather as a MET inhibitor. The problem is that on the phase 1 trials, the best responses did not have a MET amplification. So they went like, oh, that's weird. And then they did a more extensive molecular profiling. ALK translocation had been described a few months earlier, and boom, that was the explanation. It turned out to be an ALK inhibitor. So this is data from the original crizotinib phase 1 trial. Amplification was present in about 7% of patients with non-small cell. And they divided in low amplification, intermediate amplification, and high amplification based on the ratio between gene copy number and centromere. So low would be between 1.8 and 2.2, intermediate between 2.2 and 5. Don't ask me why 2.2 versus 2.3. I don't know. Maybe this was somewhat arbitrary, and high more than 5. So here, very small numbers, but here's the amount of tumor shrinkage in patients treated with crizotinib that had a MET amplification. I confess that when I read the abstract, I look at this and I said, yeah, whatever. It's really a small trial. Who knows what that means? But then you look at the presentation, and this is very impressive. So here's one of the example. Evidently, they chose the most impressive example they could find. But even given the credit for choosing the most impressive one, this is very impressive. So this is 2011 with a gigantic tumor, and then an outstanding response, and perhaps more importantly, a sustained outstanding response. Which brings me to the issue of molecular profiling. So there are multiple platforms out there. I would say that obviously the most known one is Foundation Medicine, that has the Foundation One platform. In terms of academic places, I would venture to say that we and Washington University in St. Louis are probably the most advanced ones in terms of molecular profiling. And our platform is called Oncoplex. This slide is not updated. Here we had 204 genes that we test. We're up to 252, I think. I'll be the first one to admit that from this 252, probably 240, we don't really know what to do with the result. But obviously, this is a gold mine of knowledge for us, obviously. So here's the number of Oncoplex cases that we've done at the University of Washington. As you can see, lung is number 1, as one would predict, but we're approaching now 600 cases that we have very extensive molecular profiling, and in lung cancer, we're above 150. So I'm going to talk very briefly about ramucirumab. This is the data in gastric cancer, where the drug is approved based on a trial in second line versus placebo, showing a survival benefit. ramucirumab has done fairly well. There are 3 large trials, one in breast cancer that was negative, this one is positive, and then there is the design of this trial in non-small cell lung cancer. So this was power for overall survival in second line. Patients were randomized to be treated with docetaxel alone or docetaxel plus ramucirumab. These are the patient characteristics. And this is the data for overall survival. For placebo and docetaxel, the median survival was 9.1 months, and for ramucirumab was 10.5 months. This is a difference of 1.4 months. Frequently, I've seen people look at this data and say, well, that reminds me of cetuximab in non-small cell lung cancer, where the median survival difference was 1.1 months. And I was certainly one of those that was very skeptical of the role of cetuximab in non-small cell lung cancer. I'm actually not as skeptical about this data. So I don't know if you were at ASCO. Mark Chris went to the microphone and said, ASCO has now a guideline that if there is no improvement of 4 months in non-small cell lung cancer, things should not be considered. Well, he was not precise on his comment. That 4-month difference is in first line, not overall in non-small cell lung cancer. So that's issue number 1. Issue number 2 is that positive trials in second line don't come along very often. Issue number 3, the cetuximab trial had one major problem. There was no separation of the curves for the first 8 months of treatment. And there is no explanation for that. That's when the drugs are being given. Here you have early separation, you have sustained separation between the 2 curves. So I think it's a different story. For whatever it's worth it, this has also not made into the 2A category of NCCN. It made into the guidelines as a 2B. I want to remind you that to make it into 2A has to be 85% or higher. So it's a very high bar. If it's 80%, if 80% of the institutions would vote for something to be incorporated into the guidelines, that would still be a category 2B. And here's the difference in the progression-free survival. And that's another problem of the cetuximab data as well. There was no difference in progression-free survival. All right, so this is the second column for ramucirumab and placebo is all grade 3 toxicities. And there was a difference in febrile neutropenia and no difference in hemopsis. This is obviously a vascular endothelial receptor to antibody, and a little difference in the hypertension as well. And no difference in thromboembolism. But in the last 5-7 minutes, I want to talk about immunotherapy. And that is something that has changed things dramatically in non-small cell lung cancer. And it will keep everybody involved in academic lung cancer, thoracic oncology busy for years to come. There is no question about it. So this is obviously the PD-1, PD-L1 pathway, which is a checkpoint inhibitor. When the antigen-presenting cell with the PD-L1 makes contact with the PD-1, it sends an inhibitory message to the T cell, not to act. So the idea here is that you have checkpoint inhibitors, so drugs that will put themselves between this connection and avoid the connection to be established. And that being the case, you would then free the T cells to recognize the antigen-presenting cell, and in the case of cancer cell, destroy it. So this is, as you know, there were 2 papers published, also based on phase 1 data at the New England Journal of Medicine together within absolutely true 5 minutes of the completion of the presentation at ASCO. So as soon as the presenter ended the presentation, the 2 papers were uploaded in the ASCO website. This one has 5 authors from our institution, 3 from our lung cancer group alone. And so the 2 trials were either with a PD-1 and a PD-L1. For sake of time, I'll tell you that after having treated more than 140 patients with these agents between non-small cell and head and neck cancer, we have absolutely no idea if PD-L1 or PD-1 is the way to go. The treatment is very well tolerated, except if you develop a bad autoimmune reaction. And that is fairly rare. It happens in less than 5% of cases. This data is very immature. I can tell you that as we have given these drugs for longer and longer periods of time for patients that have benefited, we have seen things that don't seem to be described, including development of type 1 diabetes over a period of weeks. So people that had normal glucose all of a sudden have a glucose of 500, and evidently the immune system has wiped out their beta cells, and they become insulin dependent. I can't answer that question. So certainly persistent after stopping treatment. So let me show you a little bit of data on other trials. So this is a drug from Genentech/Roche. This is a PD-L1 antibody. So this is data presented last year at the European Cancer Conference. 85 patients were treated in this phase 1 clinical trial. The response rate seems to vary based on smoking history. So non-smokers had a response rate of 10%, and former current smokers had a response rate of 26%. There is also some evidence that perhaps patients with squamous cell carcinoma have higher response rates. If that's separate or not from the smoking history, who knows? Obviously, as you know, patients with squamous cell carcinoma have higher rates of smoking.
Does this response rate include a stable disease?
This is RECIST response rate, and that's a great point because this is a very different response. You guys may have experience in areas that I don't, like for example, ipilimumab in melanoma. But I'll tell you that these response rates, different from chemotherapy, where you see most of the shrink in the first 2 and certainly the first 4 cycles. It's phenomenally rare to see continuous shrinkage after 4 cycles in non-small cell lung cancer. Here you can have a little bit of shrinkage, a little bit of shrinkage, a little bit of shrinkage, and just keep shrinking for 6 months, 9 months. Well, no, I'll show that too. So this is the data that was presented at ASCO. So this is a PD-1 from Merck. That's the one that it's approved for melanoma. I don't know if you guys have any experience of using this drug in melanoma. Pembrolizumab, or Pembro for those that have an intimate relationship with the drug. These are patients that were treatment naive, interesting enough, and they were screened, and 57 were positive for expression of the PD-L1. But here's the catch. It's totally non-validated data. We don't know what the cutoff is. It's 1%, it's 10%, it's the stroma, is the tumor, no one knows. The treatment, as I said, is extremely well tolerated. I'll say that the skin toxicity is an issue, and the longer you treat the patient, the more of an issue it becomes. In our experience, although there is nothing published in that area. So this is, again, as an initial therapy, the patients were treatment naive. It's a fairly impressive waterfall plot. So this is the issue you're talking about. So, these immune responses where perhaps the tumor gets actually bigger before it gets smaller. I confess that I was skeptical that that was true. There is one slide that everyone shows from a patient treated at Memorial Sloan Kettering for melanoma with one of these agents, not ipilimumab, I think it was a PD-1 antibody. And the patient came in for the first CT evaluation, had as a baseline 2 or 3 liver lesions, and in the follow-up scan had maybe 25 liver lesions. It looked like the disease had exploded. And the physician tells the story saying that, yeah, sometimes you have a little bit of growth, but, how often do you have multiple new lesions? Obviously this was progressive disease. But apparently the patient was a former retired cop from Brooklyn. And the doctor said, your disease is getting bigger, we have to take you out of the clinical trial, and da-da-da-da-da-da. And the patient said, absolutely not, and became angry. He said, I'm feeling a lot better, we are continuing it. And the doctor said, okay. And then the follow-up scans are marked improvement. So, that slide is very impressive because you look at that CT scan, you say, this is just awful. But perhaps we have to go back to the beginnings of medicine and just talk to the patient. That may be the guidance that we have to use dealing with these immunotherapies. I think if someone has a drop in the performance status, they lost weight and they have more pain, is this just an immune response and they're going to respond? I highly doubt it. So this is a case that illustrates some of our experience. So a 68-year-old female, current smoker at the time, presented with a mass in her left lower leg, so a subcutaneous metastasis, which was actually fairly large. Biopsy showed a poorly differentiated carcinoma, had some mixed squam and adenohistology. Staging showed disease everywhere. She had lung mass, adrenal, brain metastasis, was treated with the gamma knife for the brain metastasis, and the performance status of 2, got started on chemotherapy, and had evidence of disease progression in the first evaluation after 2 cycles. So, 10 years ago, 5 years ago, 2 years ago, this patient was in a boatload of trouble. Primarily refractory to chemotherapy, likely without any targetable mutation based on the very significant smoking history and the squamous cell component of the tumor. She was offered the opportunity to participate in a now closed trial between docetaxel and it's actually, there's a typo here, it's a PD-1 antibody, not PD-L1. And she got randomized to the PD-1 antibody. This is the baseline CT scan. I'm just showing one of the lesions, a fairly large adrenal metastasis. And this is the follow-up scan in October of 2013. As you can see, the adrenal metastasis is almost completely gone. And I saw this patient this week. She remains on therapy. If she had been randomized to docetaxel, she'll be dead, for sure. There is no question about it. So I find that scary. One therapy? Oh, so much better. I did have to stop her therapy this week because she has a horrific rash. This far into treatment. So, I think we're going to still learn over time how to deal with these toxicities.
Is she still smoking?
No. Well, if she is, she's denying it. So I think that the answer is likely no. The family would be all over it. They are. So thank you.